how does it different from sleeping and anesthetized?
This is, we can call it as medically induced coma. But under anesthesia, you are not going to wake up. All our anesthetic agents works on the brain.
Some patients might have a problem. Have you ever encountered such a patient, ma'am?
No.
Like, how does the body weight determine like how much anesthesia you're going to give?
So they may need more drug initially, but when they recover very slowly.
Why do you need? They need to be nil per oral.
That is the one precaution you can take to avoid all the complications under anesthesia. Chemical changes in the lung and they die because of that. It's a risk to the life.
So, hello everybody. Today I'm with Dr. Lavanya ma'am. She's our hospital anesthetist and critical care specialist. Madam is a very good friend of mine, and Madam has a very wide experience in anesthesiology as well as critical care. And she's been in different parts of the world, and she has a wide experience even in that too. Welcome, ma'am. Welcome to my podcast today.
Thanks for having me as your guest. Thank you.
Ma'am, there is a common notion that certain herbal or natural supplements don't affect any anesthesia at all. Is it so, or does it affect?
Normally, we think whatever comes with the tag natural, we think it's without
any side effects.
There's a saying in Tamil. Alavukku மீறினால் அமிர்தமும் நஞ்சு. So
yes.
that is true for everything, even for your food, if it go. So many patients nowadays think herbal or natural supplements are so safe. You can take in whatever amount, and as such, we do not know actually how the herbal or natural supplements, we don't know the exact ingredients, what they eat, what they take. So we don't know what in it, and we don't know how it's going to interact with our anesthesia, drugs or surgery, or in the how it's going to cause perioperative period. For example, some patients used to take garlic supplements. They think it is very good for their health. It's going to prevent their heart attack. But garlic is good actually, but it has some antiplatelet activities. So it can cause bleeding. Excess bleeding. So that excess bleeding, when we give some regional anesthesia in the nerve blocks, or when you give an injection in the spine, that can cause bleeding, and that can cause some problem to the patient if we don't know, and if we unknowingly give the spinal and we don't know how much they have taken, how it's going to interfere. There is no laboratory test to identify what is going to cause. So what I advise, if the patient before surgery, if they are taking some herbal or natural supplements, at least stop them for 2 to 4 weeks. So that it's completely out of your body. And once your surgery is over and everything is normal, you can go back if you have so much belief in that. If you want to take it, go back after that. But before surgery, it's better to
stop. Patients should disclose.
Patients should definitely disclose
whatever they are taking.
Because if something happens, we don't know what is causing. And the main thing is we don't know what the ingredients are. Because whatever medicines we prescribe, normally all the tablets or in the vial, we know the exact formulation, what is the dosage, how much the patient has taken. But all these natural supplements or herbal supplements, we don't know the ingredients. That is the main problem. And there is no standardization for all these natural supplements.
Ma'am, if you would like to address one common misconception that patients have regarding anesthesia, what would that one thing be?
I'm glad you asked that question, because in my practice, the most common question being asked by the patient whenever I explain to them about regional anesthesia, like spinal or epidural, like I'm going to give you a injection in your backbone, the first thing the reason they refuse that is based on people say, if you give injection, I will get low back pain later on. It has happened to my relative or to my mother or someone else I know. They have given an injection in the back 20 years ago for a cesarean delivery or for sterilization or for something else, and now they suffer low back pain. So it's very difficult to explain to the patient, like to say the injection I give today is not going to cause you a low back pain 20 years later. Because what happens is, what I think is, the patient tend to associate like cause and effect. Because we give the injection in the low back pain. And most of the time when the patient gets the backache, it's at the same space, almost at the same space. So they associate this pain along with the injection
the
they
anesthesia that
had,
has been given, lumbar puncture
yeah,
done.
a few years or 10 years ago. So I have to explain there is no scientific evidence to say that injection is going to give you a chronic low back pain, and this is such a thin needle, and it's less than your whatever you had in your hand. This is 10 times thinner because the spinal needle
is very
10 times thinner than our normally what we give for the IV drip.
yes.
So you're not going to fail. And the back pain is caused for a lot of reasons. Your posturing, your body weight, or your day-to-day activity, how stress you give to your low back. So there are a lot of factors why you get a low backache. So this injection is not going to cause. But even if I explain everything, but in the post-operative period when the patient comes for the follow-up, they say even the surgery side doesn't pay the
back
injection.
They've decided
So
they will
there
have
is,
that
yeah.
pain.
So they associate that with the injection. So it is very difficult. I'm trying with every patient, but it is very difficult to break that misconception. And many patients seem to accept the explanation I gave at that moment, but inside I know the patient is not fully convinced.
Yeah, we know that when they're not fully convinced.
It's because they want to be okay with the doctor. They don't want to put like they are disagreeing with the doctor. So they don't want to say it openly, but I feel the patient is not fully convinced. Okay.
So what is the difference between anesthesia and when the patient is anesthetized and patient goes to sleep? So what are the big difference between these two conditions? Because a lot of people will have this question, like how do you manage the patient, whether the patient is asleep? So how does it different from sleeping and anesthetized patient?
See, normally when we anesthetize the patient, that is our opening statement. Don't worry, we'll put you to sleep. You'll have a nice sleep. So we equate with that with our normal sleep. But if you think about it, it is more or less similar to sleep. But we can call it as medically induced coma.
Okay.
Normally when you sleep, you are going to be awakened by voice or pain, or if somebody touches you or shakes you up, you are going to wake up. But under anesthesia, you are not going to wake up. But how it happens, all our anesthetic agents works on the brain. So it knocks off your consciousness. It cuts off the connections between the stimulus going into the brain and to the conscious brain. So that you may feel things, but you're not being aware about that. And anesthesia is not only unconsciousness or sleeping. Anesthesia has other components. So normally we describe anesthesia having 3 components. One is unconsciousness, that is amnesia. Another is analgesia, which is pain relief. So the patient is not going to feel any pain under procedure. And another thing is muscle relaxation.
Okay.
So these are the 3 main components of anesthesia. So during sleep, you may not have all these 3 components. You are obviously going to feel the pain, and your muscles are not relaxed. You will be moving around, and it's not completely relaxed. But the major difference is this is reversible. We can call it as reversible coma or medically induced coma,
which is reversible.
Which is reversible. Obviously, which is reversible. So some patients will have the fear, if I don't go to sleep properly, how do you know how much anesthetic I need? And some people will have the anxiety, I may need more drug. How do you know? And with these monitors, we will be able to judge, because not all the patients will have the same amount of requirement. And it depending on the surgery also. How painful the surgery is going to be, how deep they are going to do, how much injury the tissues are going to have. So there are so many other things, and the patient's health condition. As I said, a young, fit adult patient may need more drug than an elderly, frail heart failure patient. They will need less drugs. So we have to balance between these two. And these monitors will help us to
in an EEG,
determine.
there will be difference in an anesthetized patient and a patient who
is awake. Yeah, with the EEG waves, we'll be able to make out. It's the raw EEG. Raw EEG will give you a lot of information.
Okay,
not all anesthetists will be having that knowledge to know to read the raw EEG, and it will be difficult on the dynamic situation to go through the raw EEG and see. So there is something called processed EEG.
Okay.
So it has a different pattern for different anesthetic agents. So with that, we can identify whether the patient
So
is
EEG is
asleep.
encephalogram, electroencephalogram, where electrical waves of the brain is recorded easily, and you can process it and it
Process
can give
it
it
will give us the information whether the patient is really asleep
or whether they have enough anesthesia.
Anesthetic agents. And when you give anesthesia, we can monitor how much the drug level is in the plasma and how much is in the brain.
Okay, that also can be
That
monitored.
is based on the mathematical compartments. If you give IV drugs and if you are giving through inhalational, through breathing, if you are giving the gases, then we can, how much the patient is, how much anesthetic gas is coming out of the breath.
Okay.
When the patient breathes out, expires. So how much is the concentration in the expired air, the breathing out air.
Mm-hmm.
So with that concentration also we can determine whether the patient is really asleep or whether the patient will need more.
Mm-hmm. This is one common question I had. Do they have dreams?
Definitely, they will have dreams, but they may not be able to recall.
Recollect it. They may not be able to recollect.
They have most of the anesthetic agents. We know that I use the medical term retrograde amnesia, so they won't be able to recall. Recall it. Yeah. That's the beauty of it. Even if they have some nightmares, they may not be able to remember that.
That anesthesia awareness, some patients might have a problem.
Some patients might have a problem.
Have you ever encountered such a patient, ma'am?
No, not really.
Okay,
not really.
It's quite rare then.
It's quite rare. What they say is maybe 1 or 2 patients per 1,000 surgeries. If you do 1,000 surgeries under anesthesia, under general anesthesia, this is not a problem when you use a regional anesthetic techniques. It's only in general anesthetic techniques. When you 1,000 patients, maybe 1 or 2 patients may be aware briefly. Mm-hmm. But I don't know, but there are a lot of bias, recall bias. The patient may not be able to. If you ask the next day, the patient may not be remember. Few days later, they may have different perception. Mm-hmm. So there are a lot of recall bias also. It's very difficult to determine the exact incidence. But my perception is under some situations, like when I said patients with comorbids or emergency situations, mm-hmm. when the patient is in shock, we may not be able to give more anesthesia drugs. So those patients are higher risk for awareness. Not normally. Normally planned procedure, if a patient comes with a good health, they may not have any problem. Problem is when you have these high risk patients or emergency situation, they may have, the incidence may be a little bit more in those subgroup patients.
This is one of the pet peeves in our hospital, I think. Strict NPO is there. So why do you need a strict NPO of 6 hours or 8 hours? Yes. Why do you need? They need to be nil per oral.
That is the one precaution you can take to avoid all the complications under anesthesia. Because when anesthesia started, they started with very rude way of giving anesthesia and very primitive medicines which are very emetogenic. Emetogenic means which can cause vomiting. So what happens when the patient is not fasted? When you put them under anesthesia, all their protective reflexes will be gone. So coming back to your first question, what is the difference between sleep and anesthesia? And sleep, we don't lose our protective reflexes.
Oh yeah,
we will be able to swallow and breathe, and we'll protect our airway. But under anesthesia, they will lose their protective reflexes. They won't be able to protect their airway. So whatever in their stomach, if they vomit or if it comes up, because all the muscles, they lose their muscle tone and all the reflexes are gone. It comes to you into your airway. You can aspirate them easily into the lungs. That is one of the still a nightmare. Even with all this modern technology and modern monitoring, everything we have, still it is the biggest nightmare for any anesthetist. At any setup worldwide, it is the biggest nightmare for an anesthetist.
So
aspiration pneumonitis, we call it. So previously it was called Mendelssohn syndrome.
Okay.
You remember Mendelssohn is
okay.
I think it was in 1946 or 47. Mendelssohn, I think, is an obstetrician.
Okay, ma'am.
So he saw a lot of pregnant patients when anesthetized. They vomit and aspirate and they develop chemical changes in the lung and they die because of that. So he discovered if you fast them enough, these things doesn't happen. So when the stomach content is less, when the stomach acid is neutralized, even if they aspirate, the damage is less. So that is how this NPO guidelines came. So any solid food, any normal meal, if you have 4 to 6 hours of digestion period. So we take the safety period of 6 hours. So that is the reason we tell the patient after midnight nothing
Nothing by
by
mouth.
mouth.
So
So
important.
because most of the time we start the cases in the morning.
Mhm.
So midnight is an easier time target to set for the patients, and nothing by mouth is easier for them to understand, and for us also to explain to the patient. If you say you can drink only water, if you can drink only tender coconut water, it becomes difficult for the patient to
Yeah, they might
understand. They
drink
might
something.
drink something else. They might eat the coconut also along with the tender coconut water. So we don't want to take
Nil
any
by mouth.
chances. Nil
Don't
by
need to.
mouth. So at least 6 hours of fasting is not a big deal for any adult patient. Sometimes pediatric patients, it is difficult to keep them
NPO for such a long
for
time.
6 hours, but it is a risk to the life. That we have to explain to the parents.
Parents.
It's a risk to the life. So even if they accidentally eat something, please let us know. That is the only thing I will tell the parents, so that we can change the time. But don't think we'll cancel the surgery and hide the fact that he has eaten something. That is the only thing I request the parents.
Yes, ma'am. And what do you think about the regional anesthesia and general anesthesia? Some people find that regional anesthesia is very safe, general anesthesia is safer. Like, what is your, as an anesthetist, what which do you prefer? Depends on the patient to
So
patient.
as if you ask me as an anesthetist, it depends on the patient and what is the surgical procedure and what are all the risk factors the patient has. So with all these things, we determine which will be the safe anesthesia for that particular patient. Not I cannot say general one is superior than the other. Each has its own side effects and risks. But personally, if you ask, I will prefer a regional anesthesia because when somebody puts you to sleep, you will feel you are losing control of your body. But some patients are very happy under general anesthesia. They do not want to be awake. Some people
Don't
are
need to
so
undergo that.
afraid of seeing the inside the operation theater, and they don't want to be aware of all the noises in the operation theater, especially in orthopedic procedures where they drill and break the bone and all the noises. For a layperson, for a first timer, it may be a scary
Yes,
experience. So it's personal preference also. If the patient is so scared and if they don't have any risk factors for giving general anesthesia, so we go by the patient's preference because we don't want them to have a traumatic experience inside the operation theater, especially when they are so anxious. That will also put so much stress on their body systems. But if the patient is open and if they don't have any prejudice and if they are happy to be away, and even with the regional anesthetic, even if we are giving a regional anesthesia, we can always make the patient give mild sedation and make them sleep. That's not a thing.
That's what.
But
we
some
also
patients will have higher risk for general anesthesia. Some patients will have higher risk for regional anesthesia. And depending on the surgical procedure, certain surgical procedures they need general anesthesia. Like if they're going to operate on the brain, open the cranium, or if on the heart, it's difficult to do it under regional techniques. But that can also be done because we have done awake craniotomy.
Okay, you've done awake
patients
craniotomy.
will be totally awake. So we use some nerve blocks. And because beyond the dura, inside the brain is painless, right? So once till that, they need some pain release. So with nerve blocks and mild sedation, we have done awake craniotomy also. And even cardiac surgeries, they do under regional techniques. So
mostly for our MI patients, like who comes with heart attack or who undergo angio, we don't give them any anesthesia as such. But yesterday also I had a patient who was thinking, you're going to put me under anesthesia. But I don't think in most of the cardiac procedures we want the patient to be awake most of the time, because that if they give an anesthetic, that leads on to some problems in their hemodynamics. Exactly, because in MI patients, we don't know how their cardiac function is, and most of the anesthetic drugs are cardiac depressants. Even on normal heart, they are cardiac depressants. So in a infarcted heart, how they are going to difficult to give anesthesia to your MI patients in the acute situation. I don't
I don't do.
So we only give sedation.
suggest.
So sedation
So
is the
mild
best thing.
sedation,
Mild
that's the,
sedation,
just to take away their
their
anxiety.
anxiety and everything.
Uh,
And we've been part of that for a long time. So it's very difficult to manage them as such. When they have a heart attack and then we do an angioplasty and everything, they are very extremely anxious, I think. And most of the time their life is in my hands and I do the procedure. So it's quite difficult.
Exactly. I've seen the patients on the
Yeah.
cat lab lying on the table
Yeah,
like
it's very
உயிரை
extremely.
கையில பிடிச்சிட்டு தான் படுத்திருப்பாங்க.
It's quite difficult to. Most of the time, and sedative is enough for them to calm down and then carry on with our procedure. So, ma'am, the another common myth that people have is that once you give anesthesia to the patient, then they feel that the anesthetist job is over. Then that's it, you're done. So, what else you do and how you involve your team?
I think anesthesia is an evolving field. Acting was an evolving field. Now I think it has come to a point of like kind of an and lot of number of anesthetists also have increased. Probably 20-30 years ago, number of anesthetists in each city or each town is very less. So they can only stay during the surgical hours. They may not be able to follow up the patient in the post-operative period. That falls on the surgeons and other physicians' shoulders. But nowadays, with the evolving anesthesia and increasing number of anesthetists, more anesthetists are available to look after the patient and to take the responsibility in the preoperative and the postoperative period. I think our job starts more in the preoperative period. By seeing the patient and assessing the risk, the patient's comorbidities, their basic health condition, how their exercise tolerance, how's their normal daily activities, how much we can put them under stress and how much they're going to tolerate that, and what is the surgical procedure. Because it depends, most of the things depend on the surgical procedure. People think more on the anesthesia side of it, but I think the risks and everything, more of it depends on the surgical procedure. How major is the surgical procedure? How much injury is going to cause to the body? And how hemodynamics is going to change? How much it's going to alter the patient's basic physiology, their normal function? It all depends on the trauma caused by the surgical procedure, how the patient is going to survive that. So our main responsibility will be to assess that, how much trauma that procedure is going to cause, how is the patient's basic health condition, and how we are going to cater to both the surgeon's need and the patient's need, and whether we can safely bring the patient out. And our role extends into the postoperative period to make the patient get back to their normal self.
Normal self. More important. I think that part is very important. Tell some challenging cases, man. Which field of surgery do you find challenging where you get to give anesthesia? Which is one field? Or
challenging is any emergency case is challenging. If it is an obstetric case also, it's very challenging because obstetric patients, they come with normal physiology. They come for safe confinement. Sometimes things go bad or go out of control where they bleed so much, because we had a patient where the patient bled almost 6 liters.
Oh.
Because our normal blood volume is only 5 liters, but we transfused her so much, and at the end of the procedure, the blood loss was 6 liters.
Okay.
So we have to extend that to hysterectomy and intubate the patient, put the patient on ventilator. And the main problem is the fluid management. As the surgeon is struggling to control the bleeding, we have to keep on replacing the fluid. So if you lose that, and if the tissues go for low perfusion, like they are not getting enough blood, if the injury becomes more, we may not be able to see the patient recover. But we struggled for like 4-5 hours and put the patient on ventilator. The next day, the patient was normal, eating breakfast in the ICU. So that was a very challenging. I still remember that patient.
But how do you manage it, ma'am? There are a lot of this monitoring and protocols, and you are caring for the patient at their most vulnerable time, and with so much responsibility and the level of understanding of the science that you need. So how do you manage this stress as well as the uncertainty and everything?
One thing anesthesia teaches you is to be vigilant always. So automatically you become like you observe everything all the time. like 360 degree, you will be observing. You'll be observing the patient, you'll be seeing the monitor, you'll be observing what's happening around the patient in the surgical field, and how even how the surgical instruments are being handled, because the sterility of the operation theater also is part of anesthetist responsibility. So during surgery, you have to make sure the whole theater environment is sterile and they're handling things in a sterile way so that the patient doesn't get any infection in the post-operative period. So as you said, it's a lot of work, but that is the reason you get your training.
Mhm.
So that becomes part of your nature, So you keep watching any small change in the tone in the monitor, or any small thing out of normalcy, you'll pick it up. So anesthetists become good
So
at
you are in present, you are
picking
on
it up.
that present and the zone now. You have to take care of the patient, and you are in the present moment. So
Exactly.
you are
Once
in
the
the moment.
patient is under anesthesia, you are the sole responsibility for the patient's well-being. It's not the surgeon.
Yes.
It's the anesthetist's responsibility for the patient's well-being. So the sole responsibility is on the anesthetist to make sure
So,
everything
and
goes right.
having a protocol, rigorous protocol, also helps you to follow
Definitely.
the protocol.
Sometimes you think these checklists and protocols, because we have a surgical safety checklist where you have to read out the patient's name, what the procedure the patient is going to undergo, which site. That's very important, because I don't know, for you remember the movie Genes, where it was a old-time movie. I don't know
Yes,
whether you've
yeah,
seen
I've
it
seen
or
it. I've
not,
seen.
where the
Yeah.
a lady got operated on the wrong side of the brain.
Yes.
But layperson's perspective, how can they do it? How can they operate on the wrong side? But if you are inside the operating theater, or if you are an anesthetist, you can easily see how things can go wrong. How easily things can go wrong. If somebody puts the scan upside down, or if somebody has marked it wrong,
Flipped
or
it.
flipped it, like flipped it to side. So it's obviously the side changes. So it's very, very easy to change. So that is why
Overlook
we should
and have
have
a.
rigorous protocols. So sometimes the pathology is not, the lesion is not outside. So you cannot see it visibly. When it is inside, you rely on the imaging. So if somebody has marked the side wrong in the image, then it's all going to go wrong. So every point you have to, and if there are too many people in the surgical list, things can obviously go wrong. So before every patient, we have to make sure. I have the habit of asking the patient before we shift the patient to lift, which side are we going to operate on? Because the patient has two legs, two hands. So they may have the same problem on both the knees. Sometimes when they come for knee replacement,
Knee
hip
replacement.
replacement,
Yes.
there's no obvious fracture or anything to see which side the patient got the problem. So both the sides, they may have a problem. Both the sides, they may need surgery. But today, which one are we going to do? Because the patient will be thinking they're going to operate on the left side. If you operate on the right side, so that will be a big disaster for the patient and to everybody. So make sure, even if after every checklist, I always ask the patient before put them to sleep, which side are we going to operate? Because the patient remembers, patient knows.
That's a very good thing to know, and it's quite important to do that also, to follow these protocols and everything. And how important is teamwork in an operation theater?
Theater is always a teamwork. So every member has to know their roles perfectly, and they have to deliver their role. Otherwise, it's very difficult. It's not a single person's job at all. We depend on our help, like ODPs, like theater technicians and staff nurses. They have to help us, because I cannot individually do everything. So without their help, and the anesthetists and surgeons should work in
A team with the
cohesion.
anesthetist and the
Otherwise,
technician and the assisting nurse, and it's a
and
big
so
team
it's
actually.
it's a team, and if you don't have a good rapport within the team, it's also difficult to work, because you'll be dealing with a lot of challenging situations. You have to get the help quickly. If you don't develop a rapport, and if they are not, they're reluctant, and they are always looking at your face for you to voice out the command, it's very difficult. Sometimes without speaking, they should know what I will need at that moment. So
Yes. So it's so
that is how
important.
the rapport should be between the team members. Otherwise, because we need only seconds
Yeah.
from the situation to go from bad to worse.
Yes,
So
that is so true. That is so true in cath lab also. So you need their team to be aware of what's happening, and they need to be ready to help us out. And the training also is important for them because we constantly train them to do these things and everything. So when you had a very difficult surgery, you are monitoring them, and after the surgery, how do you unwind yourself, ma'am, at the end of the day?
I think when you go back to your home and family, that itself is very unwinding for me. Exactly. So whatever happens, okay, I have my family to fall back on.
Yeah, true. That's a
That is
very nice way to put it, actually. Yeah.
and as doctors, we should also look after our health.
Yes, that
So
is very.
once, I mean, initially I wasn't that much physically active, or I wasn't indulging in any physical activity to begin with. Then I slowly realized, no, I can't keep on go like that. So I started doing some regular exercises, and swimming is another relaxation for me. So I become addicted to that now. So
Good thing to be addicted to.
it-
So, anyway, ma'am, how is patients' trust and doctors? Now we are facing so much challenges. As a doctor, how do you feel when you explain to patient that they need this anesthesia and this is what we are going to do? How's their reaction, and how do you overcome all those things?
Mm, I don't know. Yeah, I understand your question. Actually, when I started practice in Salem, few patients were, I faced few patients who are reluctant. It was very difficult because that was a corporate setup. Probably patients weren't um, fully confident of the doctor who is going to see them. So what I faced was situation in the UK. So I thought, okay, people are same everywhere. They have genuine concerns. You have to see them from their perspective, why they are worried. Um, so if you try to see it from their perspective, then probably you expect, because it may be a everyday practice for you.
Yes.
But for that patient, that is the first time. So they may not understand, they may not know. So explain a little bit more to them. Sometimes when you are tired, you are end of the day, you had a hectic work day, and end of the day somebody is asking, it's human nature to become impatient. But probably you can tell them, okay, I can explain again tomorrow, or ask one of your team members to explain, or write down. Better way is probably, I think now, ask them to write down what all their doubts.
Yes, that is
The
quite
I
helps
think.
me a lot, actually.
So once they write down, also they will also realize, okay, these are all silly questions. These I may not need to ask the doctor. I know the answers, and it gives them also some time, and for you also to some time to reflect, and probably take the questions, and you can answer them probably the next day or before surgery, or
Yes,
something
and
like that. We
most
can plan
elective
for
surgeries, it's
it's
quite easy to
easier.
explain. Emergency surgeries, it's
Surgeries, it's difficult.
difficult. It's
Emergency
difficult for
surgeries,
us.
it's difficult. So that is the reason I make sure we see the patient. Like any elective procedure, I always request the surgeons, whenever you plan for the procedure, please send the patient to us.
Yes.
So
There
that
is a rapport.
rapport between the patient and the anesthetist, and we also beforehand know what kind of patients we are going to deal with on that particular day, and how we are going to prepare our team. Because I have to tell my team what I need for that particular procedure. Because recently we had a patient who's an ankylosing spondylitis, who came for a hip
Yes, they have
replacement
a stiff
surgery.
hip and stiff
Stiff
back.
spine. So already in another hospital, they were trying to give him a regional anesthesia technique, which failed. So I explained to the patient, okay, I don't want to poke your back. I know it's going to be difficult. Why should I poke your back again, knowing that somebody has failed? So I'm not going to satisfy my ego by doing that. So I'll straight away give you a general anesthetic. But I know giving general anesthetic is also difficult for that particular patient, because his neck is so stiff. So I may not be able to put the tube down his
The intubation might be very
windpipe.
tough.
So intubation maybe, it'll be definitely tough. So I have to prime my team members. What are the difficult intubation gadgets I need? If this fails, I need that. So what is plan A? What is plan B? Plan C? So that they will also be
Ready
prepared.
for the.
So if I don't know about the patient, if I just see the patient in the theater, where is the time for prepare everything, for me to mentally prepare and to prepare my team members and make sure all the gadgets are available and they're in working condition. So it's better. Always, if it is a planned procedure, always see the patient
Before develop
beforehand,
the rapport
when a
and then
week
go.
before or few days before, and and you have time to answer all their queries also.
Yes.
So they also get the satisfaction, okay, they have taken time to plan everything. Even if something goes wrong, unfortunately, so the patients and patient relatives will know they took all the necessary steps.
So, what advice you would like to give a person who's now pursuing or interested in taking anesthesia? How anesthesia field has evolved when you are doing as a PG, and now how it will be when they take it as a PG and move forward in life?
Anesthesia has evolved so much, and maybe like in India, if you take, they think there are a lot of anesthetists, you have to compete with each other. That goes for any profession,
Any field.
any field. So if you have a passion of doing that, and when a young doctor comes to me for an advice, I will say to them, if you like little bit of adrenaline rush now and then, then you're okay for anesthesia. And if you yeah.
Very nice way to put it. Not the chronic adrenaline rush of cardiology or neurosurgery. Both of them have a chronic adrenaline. It's tiring sometimes. And anesthesia is correct. Right? I agree.
Yeah. And for female doctors, I think it is a good field. Good field. So you can take a break whenever you want.
And you can go to a case.
You can go to a case if you want to. If you don't want to.
Only thing you can't work from home. But
there is nothing telemedicine. And the same time, AA is not going to take away your job.
How AA will affect anesthesia? AA cannot affect anesthesia.
You need a human to deliver. It can improve the dosage, how much drug it's going to deliver, and how much the patient is going to need, and it may become more precision science, but it's not going to take away your job.
Yes,
you need a human there.
AA is never going to take away surgeons or anesthetists. You're definitely, at least, you need that human monitoring and the human touch to be there, and it will always be there, I think. Nice talking to you, ma'am. We're very glad, and thanks for coming to my podcast and explaining so much variety of topics we talked today. Where can we find you, ma'am? Are you in social media, or you are oblivion to social media?
I'm not into any kind of social media except WhatsApp for my work purpose. Not into social media at all.
Okay. Anyway.
Thanks for having me.
Thank
it's
you,
nice talking to you.
Okay.